Hi, my name is Dr. Robert Kaufmann. I'm about to go beyond the terminus. Today we're going to discuss armamentarium for accessing canal orifices. If you have excellent magnification, a good light source, and you've made an endodontic access, you're now faced with attempting to locate the orifices. Part of the problem with using any rotary-driven device is that the head of the handpiece frequently interferes with your sight line. Indiscriminately drilling into the floor of the access cavity can only serve to weaken choroidal tooth structure through unnecessary dentin removal. It destroys any potential pulp floor landmarks and is an inefficient method of gaining access to the orifice. Endodontists basically use two methods in order to deal with this initial canal exploration. The first method is to use an ultrasonic tip. Many manufacturers make them. The tips come in various configurations, lengths, shapes, and can also be coated with abrasives such as diamonds. They're extremely efficient instruments, but must be used with caution. You can't indiscriminately turn up the ultrasonic generating device up to 100% and expect that the tips are not going to fracture, regardless of who makes them. Currently, I'm using an older Satellite P5 Spartan cart-mounted device. The manufacturer of the EIE2 tips that I frequently use recommends a maximum power setting of 85% to prevent tip breakage. Failure to adhere to this maximum setting has potential for fracturing the tips, which can be quite expensive to replace. It's also preferable to use them with water spray, though I've never found a very efficient way to use the instrument. Regardless of how closely you may suction, the water spray can sometimes interfere with the visibility of the area you're trying to instrument. Manufacturers generally do not recommend they are used dry. When used dry, ultrasonic tips have one big disadvantage, and that they generate dust. I will frequently use these tips dry at a slightly lower power setting than optimal, which aids in visibility. This allows my assistant to clear the working area by application of air with the use of this Stropco air syringe. These tips require a light touch to cut efficiently. Using this method of dentin removal is very technique sensitive and depends upon extremely good visibility and experience. They're also an essential part of the techniques that we use to remove broken instruments from canals. Another very efficient instrument is a derivation of the Mueller burr. These slow-speed burrs, known as Munce Burs, were created by Dr. John Munce at CJM Engineering. The Munce Discovery burr line is available in several lengths of 28, 31, and 34 millimeter long burrs. These burrs come in head sizes of quarter, half, 1, 2, 3, and number 4 round. The advantage with these burrs is that unlike conventionally sized long shank slow-speed burrs, the extended shafts position the head of the contra angle far away from the axis, allowing visibility of where the burr contacts the dentin. This prevents indiscriminate removal of the dentin and helps us see better and conserve tooth structure. Furthermore, unlike ultrasonics, which generate a lot of dust, these burrs can be used dry with very little dust generation and much greater visibility. They're very useful in cases where deeper exploration of the tooth is necessary. Canal exploration in the case of calcified teeth is tricky business. This is especially true in teeth that have really thin roots. We don't have a lot of latitude to explore and little room for error when attempting to find canals in narrow roots. A misdirected burr or ultrasonic tip can easily cause perforation of the tooth and can also contribute to the thinning of the dentin and eventual fracture of the root or tooth. In any case, where we suspect the canals may be difficult to find or where the canals are not easily discernible on a radiograph, a CBCT tomograph should be taken preoperatively and as often as necessary in mid-treatment to allow us to redirect the access to the proper angulation that enables us to find the canal. Endodontists frequently deal with cases that have a high degree of difficulty. There are certain situations in which multi-rooted or multi-canal cases can have orifices and canals that are very difficult to locate and to treat. After a concerted effort has been made at the initial appointment without success, it's sometimes advisable for the clinician to close the case for the day and return at the next appointment. There's a phenomenon in endodontics which is akin to you can't see the forest for the trees. This can happen when a clinician has been working in an axis for a long time during an appointment trying to find the orifice or canals and becomes disoriented. In frustration, they sometimes start looking in places that risk perforation. It's been my experience over the last 38 years as a specialist that it's better to close the case at that point than get what endodontists like to call a new pair of eyes. At a future appointment, with a fresh perspective, it's amazing how I then immediately find what I've been looking for. simply because I'm looking at the case differently and I'm examining the case from a new, fresh point of view with a new set of eyes. So if you're struggling with the case, stop, reappoint at another time, or consider referring the case to an endodontist before any mishaps occur. Remember, when we do the right thing, we both get better, patients and clinicians. Don't forget to subscribe to this free channel. Tell your friends and colleagues. Thanks for stopping by, and I look forward to next time when we go beyond the terminus. See you then.